So my name is Jared Forrester. I'm one of the fourth-year general surgery residents, and I'll be talking about, let's see, there we go, clean cut quality improvement outcomes in Ethiopia and how we are able to improve surgical quality and reduce postoperative infections. This work was made possible by a generous grant from the GE Foundation. So over this short 8 minutes we have together, a couple things I'd like to leave the audience with is really how do we get safe surgery in low and middle income countries. And one way that we found is through a quality improvement program that really tries to improve processes of care and thus decrease infectious complications. And we do it through the team. We build a team at each hospital consisting of nurses, anesthetists, surgeons, and hospital administration to come together and identify improvement opportunities, prioritize these interventions, and deliver on it over the 6-month engagement. And importantly, we've had really great capacity building, starting with these 5 centers that I'll talk about today to scale it up to 7 more, and mainly through Ethiopian driven. So to start, I don't need to belabor the point to a group of surgeons, but surgical infections are a big deal. And this was importantly shown by Global Surgery how large this was of a problem in low and middle income countries in 2018 when they published in Lancet, showing that about a 2 to 3-fold higher rate of surgical infections in these settings. Now, guidelines do exist for how do we reduce surgical site infections, but the how, really the implementation strategies are lacking for how to change human behavior to do so. And so this is where we've thought of Clean Cut as a quality improvement program to do so, really with the backbone in a previously proven intervention, which is the surgical safety checklist. Where we're working is on the continent of Africa. Spent 2 years living in Ethiopia, which is wedged between Somalia and South Sudan. The 5 sites we were working in are highlighted in red in Jima, Addis Ababa, and Fiche. And what we were measuring to start was two pieces of quantitative data. One was observations directly by trained nurses in the operating theater to infection prevention standards, 2 of which were just inherent to safe surgery in general, and that's appropriate skin decontamination of both the surgeon's hands and the patient's surgical site, as well as maintaining a sterile field. 3 of them are embedded within the checklist, and that's making sure we're using sterile instruments. Another is that we're making sure we're using the right antibiotic at the right time before surgery to have efficacy, and also that we're decreasing retained surgical items through standardized gauze counts. And lastly, that we're using a communication tool like the surgical safety checklist to improve care. We then follow these patients through 30 days post-operatively, both in the hospital and out of the hospital, with our primary outcome being surgical site. This is an operationalized definition, things like pus draining from the wound opening up, foul smell, so that way it's easy to capture. And as well as secondary outcomes that could be indicative of a surgical site infection, like hospital length of stay, reoperation, or dead or alive at discharge, as well as other infectious complications. So we then couple this with process mapping. So we walk around with the lead at each hospital to generate these hospital-specific process maps. And what it is there's a whole process that underlies each one of these things we're measuring in the operating room. And anything that goes wrong in those things can cause a change. So, for example, within instruments, we were measuring with the observations 1A and 1C. We did a sterile indicator change color and were the instruments wet. But there's a lot of things that go on to get to that. How are instruments clean in the decontamination area? Do we have things that need to get repaired? Do we even have sterile indicators? And likewise, when they get sterilized, do we have distilled water? Do we have electricity that's running? Do we even have a functional autoclave? So combining both our quantitative data with this hospital-specific process map is a really powerful tool for generating quality improvement. How we did that is through getting our team together. So we would have a baseline period of a month where we would review our baseline process maps, our adherence data, and our patient outcomes, and then together brainstorm and prioritize feasible solutions that we can deliver on in a timely manner. Easy wins in 1 month, medium wins in 3 months, and long-term wins in 6 months to deliver on this. What we found is a lot was focused around education. We were able to improve checklists used through doing checklists that were adapted to the local environment and as well in the local language. We had partnerships with education to improve the cleaning and decontamination of these instruments and as well to adapt to what was available in terms of sterile indicators. And as well walking through the laundry and making sure there's no cross-contamination between our laundry and linens. So this is a spider plot really showing how we did. The before is the red and the blue is the after. And this is 2,200 patients over these 5 hospitals over 2 years. And we saw a baseline, they had about 2.9 of 6 adherence score to start with, and that rose statistically significantly to 4.5 out of 6, and we saw it across all things. I think it's important to see that we didn't reach 100% with any of those. I think that's something that to go the quality improvement, it takes continual improvement and continual effort to try and drive change. So in terms of our overall change, did we have an effect? So within just raw analysis over our 2,200 patients, we saw a trend towards decreasing infections from 7.4 to 5.8. But importantly, when we control for wound class, urgency of operation, among other demographic data, we found a statistically significant risk reduction post-implementation of our program. And importantly, we found that improved compliance reduced the risk. So when we compared those that scored an adherence score of 3 to 6 versus those of 0 to 2, we found a 46% risk reduction with implementation. Now, of course, there's limitations with any study, and ours is a pre and post design, which is similar to most checklist-based studies. But importantly, the Ministry of Health had a really strong initiative trying to implement both a quality improvement metric and as well surgical safety throughout the country. And so randomization really wasn't possible. Of course, anytime dealing on the ground, there's data collection challenges, but I think it's really testament to our collaborative work effort that we were able to get 98% follow-up at 30 days. And this is from patients traveling 300, 400 kilometers away. And we did it through phone follow-up that we recently published in World Journal of Surgery. As well, I kind of mentioned earlier that it's unable to obtain full compliance with all the 6 standards, but I think we're onto something here, and it's going to be encouraging to see when we process this next 7 sites how we're doing with this program. So I think some of the takeaway points is really that we're able to improve compliance with some of these critical infection prevention standards. And this was in a setting when the country was in a state of emergency for pretty much the 2 years while we were there. So we're doing it under challenging settings and being able to reduce the risk of infection in these times. And importantly, I think we have enthusiasm for ongoing site enrollment, where we had kind of a trainer of the trainees. So the first few sites would then train on the next few sites, all in Amharic or in the local language to try and improve care. So I'm the one presenting, but it's a whole team effort. And I'd really like to thank Dr. Wise, Dr. Tukawande, and the whole Ethiopian team for giving me the opportunity. Love to take any questions.
Great, thank you. We already have a couple of questions. Dr. Hahn says, nice work, Jared. This is a very labor-intensive intervention. How can you scale, and how do you ensure these processes are sustained? And I have a follow-on question for that, which is, do you have a plan to look at, you're talking about training the trainers and sort of a ripple effect. Do you have a plan to circle back and look at fidelity with that ripple effect?
Yeah, so that's a great question. I think if I had an answer to sustainability, that would be incredible, and I'd be giving talks all the time. I think it's always a challenge, especially in these settings. As I said, this was a state of emergency while we were doing it. But I think importantly, how we really sustain it is through an ongoing engagement. I think all too often global health is a parachute in, parachute out type of thing and try and talk about it. But there's another fellow after me, Nicole Starr, who's a general surgery resident at UCSF and has spent 2 years before in Ethiopia as a Peace Corps volunteer, so she's fluent in Amharic, and she's living there for 3 years. So by having a continued presence with Lifebox in Ethiopia, we're able to have this, and we also have hired Ethiopian program managers, and we have Ethiopian champions that are able to teach this program. And I think in terms of scale, that's also another challenge within this. You know, this was a labor intensive. This is a photo of GMO, which is the first one I was in for a year trying to pilot this and develop it. But then over time, we're able to see that we're able to do a little bit more lighter touch and have one central hospital that's then able to reach out and use the model of the Federal Ministry of Health to reach out to 4 or 5 sites that are their sister centers to be able to try and teach these practices. Okay,
that's great. Next question is from Charles Liu, and Charles, it's great to see you on here. How did you get buy-in from the Ministry of Health and hospital leadership? And do you think this could be reproduced in other low and middle income countries in the region, such as Uganda or Rwanda? And I also wanted to add on to that. Even in the US, we, for NSQIP, for example, a lot of you weren't around when it first rolled out necessarily, but NSQIP champions were fundamental to getting NSQIP accepted in hospitals. Do you see ways, so my follow-on question is, do you see ways that would translate to other settings, not necessarily low and middle income countries?
Yeah, I think it's interesting that kind of human behavior is similar regardless of the cultural context. And we found, similarly to a lot of the checklist-based studies that have come out of Ariadne Labs, that if we don't have a champion at a hospital, we don't have someone who's going to be driving that, then it's really kind of a moot point for doing this. And so if we had a champion at the hospital, we had incredible success. In terms of how to develop buy-in, that took a lot of time. I think that took really a show of faith. I showed up every day. I would kind of participate in surgery to show that I was interested in surgery, show that I was part of the team. And over time, kind of get brought into the surgical culture and environment within the hospital. And then over the 2 years, became part of the family. In terms of the Ministry of Health buy-in, this was kind of a part of a global work of Safe Surgery 2020, which was a large initiative by the GE Foundation, which had different pillars that was driven by Harvard, PIGO, and others, though they were working in different centers than we were. But it was, you have to get the green light from the Federal Ministry of Health, especially in Ethiopia, before trying to do that. We do have other centers that are within the Kasekta region that are interested in rolling this out, and we're actually, before COVID, we were having centers that we were looking at in India for scaling this up.
Okay, great. We have time for one more question. I don't see any more in the queue, so let me ask you a quick question. Did you and Nicole basically sort of plan in advance or huddle in advance on any issues that she might need to confront that would be different from issues that you need to confront? Probably the most obvious is that you're a man and she's a woman. Any other issues, or did you specifically talk about that one?
Yeah, no, I mean, when the kind of, we started meeting 6 months ago in terms of the end of my fellowship in San Francisco, and then also she came out to Ethiopia, and so that way I could introduce her to all the hospital setting and leaders and everything like that. I think the man-woman issue is something that is a real issue in Ethiopia or many of these countries. But I think she's an all-star. She fluent in Amharic. She knows the language. She is just incredible. I think it's going to be hard to actually pull her out of Ethiopia. It was a huge advantage, and she's going to do great things with this program. So I think having a set onboarding process and also making sure that we have continued boots on the ground is important for any sort of sustainability.
All right, that's great. Thank you so much.